So, good evening, everyone, and welcome to Hope2Sleep's fourth webinar. Tonight we've got a special focus on sleep apnea in children. So, my name is Tim, I'm the Vice Chairman for the charity and will be the moderator for the event. So, this webinar is going to be between 1 and 1.5 hours, depending on the questions at the end. Just to reassure you that although you can see us, we cannot see you. So, please just sit back and relax. If you'd like to ask any questions, then you can do so in the Q&A tab at the bottom of your screen. And we'll do our best to get through them all by the end of the webinar. So our first speaker tonight is Professor Heather Elphick, and she is consultant in Paediatric Respiratory Medicine at Sheffield Children's NHS Foundation Trust. A mouthful. She's also Hope2Sleep's Paediatric Medical Advisor. So Heather will be talking about the signs, symptoms, and treatment of sleep apnea in children. Following Heather, we have Janine Reynolds, who is the Paediatric Sleep Disorders Nurse Specialist and the Team Lead at Sheffield Children's NHS Foundation Trust. So Janine will be talking about the nurse-led service, the screening process for sleep apnea in children, and also the long-term life-changing impact of successful therapy. Then our last session tonight will be a bit of a double act between Hope2Sleep's founder and CEO, Kath Hope, along with Carolanne Murphy, who's a trustee at the charity. She's also an early years practitioner and NHS healthcare support assistant. A lot of Carolanne's family suffer from sleep apnea, including her children. So Kath will be asking her a few questions about her family setup and advice for families in similar situations. And then we'll wrap up with a Q&A. So that is enough of me, and I'd like to pass over to Heather.
Hey, thanks very much, Tim, and thank you to Kath for asking me to speak at this webinar. It's a pleasure to speak to you about obstructive sleep apnea in children. I've been looking after children with sleep apnea for about 15 years, so I hope I can give you some information based on my experience of what sleep apnea is, how we recognise it, how we monitor it, and how we treat it, and then just a little bit about some new developments in children's sleep apnea as well. Sorry, just having trouble moving the slides. Slides are not moving. There we go. Sorry about that. Okay, so obstructive sleep apnea. The word apnea comes from a Greek word meaning without winds. So literally it means that the child has not got any breath for the duration of the apnea. And it's a symptom of intermittent upper airway obstruction during sleep. So if you can see from the diagram, the picture on the left shows an airway that's open, and the picture on the right shows a diagram of a blocked airway. So this is what happens when children have obstructive sleep apnea. And the most common cause of obstructive sleep apnea in children is enlarged tonsils and adenoids blocking the airway. So there are three factors involved in paediatric obstructive sleep apnea. One is blockage of the airway, and the second is collapse of the airway. So this happens in children that have underlying conditions that might lead to some weakness of their airway muscles, such as neuromuscular conditions and Down syndrome, or children with obesity can also get collapse of the airway due to the fatty deposits around the airway. And then the third cause of paediatric obstructive sleep apnea is abnormal facial structure in children that are born, particularly with syndromes or other conditions that mean that their facial features are predisposed to a small airway. And then in addition to those three factors that cause the apnea, there are underlying genetic factors as well. And some specific genes have been found that impact on factors such as the thickness of the oral tissues in the mouth and facial structure, which also play a role in obstructive sleep apnea in children. So these are some pictures of some of the high risk groups for apnea in children. So on the left-hand side, we've got 2 children with muscular conditions. So the little boy on the right with the, at the bottom with the stripy t-shirt has Down syndrome, and the boy on the left has a neuromuscular condition. So as I said, these are conditions that involve muscle weakness, and that can involve the muscles of the airway. Then on the top right hand side, we've got a couple of children with specific conditions. So the baby with a very small chin has a condition called Pierre-Robin syndrome, which involves a cleft palate and a very small chin and jaw, which leads to a small and collapsible airway. And then the little girl has a syndrome called Treacher-Collins syndrome, and you can see she's actually got a tracheostomy in her neck, which is helping her to breathe because she's got such severe obstructive sleep apnea due to her underdeveloped facial features. And then the picture on the right-hand side at the bottom represents a child with obesity, and unfortunately, as well as with obstructive sleep apnea in adults, we do find that children that are very obese can also have obstructive sleep apnea. So what are the consequences in children? Well, there are 2 things that concern us about a child having sleep apnea. The first is sleep disturbance. So when the child's having apneas, they can terminate in an awakening from sleep as the body tries to correct the abnormality overnight. And the constant sleep disturbance from recurrent awakenings due to apnea can lead to difficulty with the child being able to concentrate at school. And you'll see here that actually challenging behavior such as hyperactivity, impulsivity, irritability, and just generally rebellious and aggressive behavior is actually more common than sleepiness in children. And that's one of the main differences between children and adults in terms of how they manifest their tiredness during the day. And then in addition to the sleep disturbance, we also worry about fluctuating oxygen levels. And if children's oxygen levels are dipping on a regular basis, then in the longer term, it can lead to difficulties with blood pressure and heart failure, just as it can with adults. So these are some of the symptoms to look out for in children with sleep apnea. So most children with obstructive sleep apnea will snore, but not all children that snore have obstructive sleep apnea. So I put some figures here. 12% of children snore, but only 2% of children have obstructive sleep apnea. So the symptoms of sleep apnea are snoring and one or more of the other symptoms that I've listed here. So often the child will have laboured breathing, and this is often what the parent will notice when they watch their child sleeping at night. And then I put opposing chest and abdominal movements. So this is where you can see the chest and the abdomen moving in opposite directions at the same time. And that's a sign of increased work of breathing. And that is one of the most accurate signs for diagnosing sleep apnea in children. Apneas, obviously, if you notice your child having apneas, in other words, breathing pauses, then that's it is a sign of sleep apnea. But actually, many parents don't share a bedroom with their child, and so the child may be having apneas overnight, and the parents may not be aware of that. And very often in clinic, we have parents that come in and say, well, I had no idea their breathing was as bad as that until we shared a room in a hotel, or we went on holiday in a caravan or camping, and then they realized just how bad the child's breathing was. So if the parent hasn't witnessed apneas, it doesn't mean the child does not have obstructive sleep apnea. But often they can hear gasping, snorting, grunting, that sort of thing from another room. If you see the child mouth breathing, so in other words, that they're sleeping with their mouth open, then that's a sign of nasal obstruction. And then just the more subtle signs, so sometimes the child will just be very restless and have quite agitated sleep because they can't really get an optimal position for their airway in order to get enough breath and oxygen in overnight. And sometimes they sleep in unusual positions. So sometimes they will sleep with their neck really extended backwards, again, to optimize their airway. Sometimes they'll be sweaty, have a preference for not wearing very much in bed. And And bedwetting can also be a sign of sleep apnea because of the sleep disturbance that it causes. So how do we assess a child in clinic if they've been referred to us with obstructive sleep apnea? Well, we take a history first of all. So we'll ask the parents to describe what they are concerned about, and we'll ask specifically about the symptoms that I've just listed above if they're not volunteered by the parent. And then we'll examine the child. The child with nasal obstruction has a typical sort of face with the mouth open and nasal sounding speech. And then we'll ask them to open their mouth and look and see if they have large tonsils at the back of the throat. We can't see the adenoids. Often when the child's got enlarged tonsils, they've also got enlarged adenoids, but they are right down at the back of the nose and we can't see them just by opening the child's mouth. We can't see them unless we've got a scope that we put in through the nose, which we don't generally do in clinic unless there's a particular reason to do that. But one of the other signs of long-term sleep apnea is actually chest deformity. So I've put a picture of that on this slide so that you know what to look out for. Not all children with this chest deformity have obstructive sleep apnea, but it can be a sign of ongoing increased work of breathing, of which one cause is obstructive sleep apnea. So it could be a sign to look out for. And then I put home video because home videos are really useful to us in clinic. Because we can't, often, we'll examine a child in clinic and their breathing will be absolutely fine. It's only when they go to sleep that they have breathing difficulty. And so in addition to the parent's description of what goes on, it's really helpful if they've taken a video of the child's breathing, because then we can immediately see the extent of the sleep apnea and we can diagnose it there and then by looking at the video. If we suspect obstructive sleep apnea, sometimes we go straight for treatment without doing any overnight monitoring. But sometimes if there's some doubt or if, some abnormal features, then we'll monitor the child's sleep overnight. And the most common tool that we use to do that is overnight oximetry. It's very commonly used as a screening tool. If there's presence of the signs of obstructive sleep apnea on the oximetry, as I've included on the diagram here with the red lines dipping down in clusters representing dips in the child's oxygen levels. That's very characteristic of severe obstructive sleep apnea. So if we see that, then the oximetry is sufficient. If there's still doubt, then we may want to go on to do a more complex sleep study. So we can use polygraphy to look in more detail at children's sleep apnea if necessary. And we tend to use this to assess complex sleep apnea. So we would use this more commonly in children with underlying conditions, such as the ones I mentioned earlier, rather than those with simple tonsils and adenoids. And we can use it to diagnose different types of sleep apnea as well. So there are other types of sleep apnea that we may want to try to differentiate between that and obstructive sleep apnea. Polygraphy is normally done in a specialist sleep unit, and I've put a picture of our sleep unit in Sheffield here. Our sleep unit's located in a house, which is a really nice environment for us to do sleep studies on children. And we'll do a polygraphy if we're about to start ventilation or CPAP treatment on a child as well. So that brings us to treatment. As I mentioned, the vast majority of children with obstructive sleep apnea have large tonsils and adenoids. And in children without any other underlying conditions, removal of the tonsils and adenoids, if the sleep apnea is bad enough, is curative in probably over 90% of simple cases. But for those with persisting obstructive sleep apnea or underlying conditions, then we may want to use additional treatments. So they range from nasal steroid sprays to anti-inflammatory medications. In severe cases, we may need to use overnight ventilation. So that's what's pictured here. And these are two of my patients who've given permission for me to show their photos. And you can see that wearing a mask on the face is sometimes a very positive experience for the child if they can sense that it's helping them with their breathing. In very rare cases, we use orthodontic procedures or appliances, but really in children, those are only used for children with a sleep apnea in association with another dental problem. And then, of course, if the child is overweight, then we do encourage weight loss as a cure of their underlying problem. Right, so I now got a couple of slides just to tell you a little bit about some new developments in paediatric sleep apnea. So new developments in monitoring. As you imagine, it can be a traumatic experience for a child coming into a sleep unit to have a sleep study done, particularly if they've got to have lots of sensors stuck on them. And there's lots of work going on in research at the moment to try to develop different ways of monitoring children at home rather than having to bring them into hospital. So if we can get the same results on a child at home as the results that we would get in hospital, then that has lots of obvious benefits to the child, both being more in their comfortable environment, people not having to take any time off work or school, and getting a more representative study as well, because the child's more relaxed in their own bed. So this is just one example of those, and this is something we're looking at the Children's Hospital at the moment. So the AccuPebble has been validated for use in adults and is currently being validated for children. So potentially some exciting technology on the horizon. And this is another new development in terms of the treatment of sleep apnea in children. For those of you who have children that use CPAP masks, you'll know that the two children I showed you earlier are not necessarily representative of all children that wear CPAP masks, and many of them have difficulties finding a mask that fits. And that can lead to over-tightening and then pressure sores on the face, or it can lead to suboptimal ventilation and lots of alarms going off overnight if it's not fitting properly. So we've been doing some research at the Children's Hospital to develop custom-made CPAP masks, and we have got to the point where we've developed a prototype and shown that in 73% of the children that we trialed it on, they reported that this was more as comfortable or more comfortable as their usual mask. But a problem that we came across was that in 45% of cases, they still weren't able to wear the mask properly because their headgear didn't fit properly. So that's the next stage of the development for us with the research. But you can see we've got some very positive feedback from parents. And so I would like to take this project further and see if we can actually get a better headgear for these children as well. And I've just written on here that we are recruiting for a parent and patient interest group. So if anybody is interested in helping us with this project in terms of giving us some feedback, then Kath's very happy for you to contact her about that. Thanks, Kath. So just in summary then, paediatric obstructive sleep apnea, when and where to seek help for a child that you suspect might have obstructive sleep apnea. So if a parent has witnessed apneas or has a concern about their child's breathing during sleep, then they should go and get some medical help because they might have sleep apnea. If the child is showing daytime tiredness or behavioural problems with tiredness and sleep disturbance associated with snoring and some of the other features of airway obstruction that I described earlier on, then again, that's a good idea to go and seek medical help to check whether or not the child might have obstructive sleep apnea. And the GP or the health visitor would be the first point of contact. And just my final tip, as I said before, if you do go to seek medical assistance, then take a home video if at all possible, because it's really helpful for the clinician in making a diagnosis. Thank you very much. That's it. And I'm very happy to take any questions later on in the Q&A session. Thank you.
Thanks, Heather. That was really, really interesting. Thank you. I've got a quick question. What is the average age of the children that you see in your clinic?
Yeah, that's a good question. So that's the vast majority of children that have simple adenotonsillectomy, the peak age is around 3 to 4 years old. So these are children who are having tend to be having recurrent viral infections, and their tonsils and adenoids have enlarged as part of the immune system to fight those infections in that age group. So they tend to be the young children with tonsils and adenoids. Then the children with obesity and the more sort of muscular problems as a cause for their sleep apnea, they tend to be the, get worse as they get older. So that tends to be the more kind of teenage group. So they're the sort of the two main groups that we see.
Cool, thank you. Right, on to our next speaker then. So I'd like to pass over to Janine.
Hello, I'll just share my screen. Can you see that, everyone?
Yes.
Yes. So I'm Janine Reynolds, and I've been working alongside Heather for 14 years. And so I'm going to be presenting all about my experience of sleep apnea and its management as part of the Sheffield Children's Hospital Sleep Service. Thank you, Kath, for inviting me. It's delightful to be here. I'm just struggling sharing my, there we go. So the outline is a brief overview of my nurse-led service at the Children's, explaining the screening process for OSA. But I must admit, our consultants are pretty amazing at filtering these through, because we always sort out the medical before they come to us. And giving a case example and describing the life-changing impact from the experience that I've had as a children's nurse. To give you a bit of a background, I've been doing it 14 years, and I started as a sleep diagnostic nurse on the sleep service. So I've got 9 years experience of setting up and monitoring over 1,000 overnight sleep studies. And I can tell you that I have witnessed obstructive sleep apnea, and I can do a definite retake, but I'm not going to embarrass myself tonight, of the signs and symptoms, and waking the children up in the middle of the night, reassuring parents, listening to them, the tears and the revelations and the experience they've had to go through. Because as you can appreciate, it's the most awful, fearful thing, anybody watching a child not being able to breathe. So it's been a privilege and an amazing journey in my sleep experience, helping these children as a nurse advocate to help them through that experience. And it still goes on to this day in my nurse service. And after this 9 years experience of doing all these sleep studies, Heather wrote me into doing some research, and that's where my journey began. And what a life-changing impact that research did, looking into the prevalence of sleep apnea in Down syndrome children that are already predisposed because of their etiology with their large tongues and the small airways. And my goodness, we picked some up and got them straight in. And now we do yearly monitoring, which is a life-changing, and I'll go on to explain about those life-changing impacts later down the line. Following on from this research, I quickly went into drug trials and became a fully fledged research nurse. But I miss my clinical experience and being with these absolute beautiful kids of every condition. And I must admit, I just love, any child, but they do have a special place in my heart, especially the old ones that are recurrent, and I still get to see them. So we realised, following all this research and my vast experience on the sleep unit, we were seeing a lot of negative kind of sleep studies, but they still persisted with sleep issues. And as you can appreciate, with obstructive sleep apnea, they continue to wake, even though you bring them off the CPAP, you remove the tonsils, and it's the science of sleep. We are creatures of habits, And children are more so because they haven't been corrupted by life and curveballs. So they do wake frequently, and this is what I now specialise in, getting sleep back on track. And it's the most wonderful job in the world. I absolutely adore it, you know, because as I'll explain, it is a life-changing impact when you get sleep back on board. So basically, our screen process is a really good process. And like I mentioned before, our consultants are pretty amazing at ruling out the medical, but we do a fine screening process. We now do a 20-page assessment, and my goodness, do we come up with every orifice of life. We look at the predisposing, perpetuating, and factors that hinder sleep, and give a detailed history and screen through all the medical issues to rule out all those medical and ongoing sleep issues, and there's loads. The screening process is one of the boxes on my 20-page assessment that not only looks at the medical, but all the well-being right back from birth. So we really pick out what is affecting children's sleep. And as you can see further down the line is the sleep disorder breathing. And like Eva mentioned, it's the snoring, the pauses, the gasps. We take a real detailed history, and we're extremely good at getting those clips so that parents can really explain, and we pass them straight back to our consultant-led clinic because we're really well supported and heavily supervised. And alongside these, we refer for sleep studies because most of our nurses have been diagnostic nurses on the sleep unit, so they come with a wealth of experience to be able to understand and appreciate when it's obstructive sleep apnea. So the referral on, we obviously meet once every week, but our consultants are on tap to us. We constantly email. I think me and Heather was emailing last night over different cases, and we refer back to them if they need adenotonsillectomy hypertrophy. We're getting a lot of obesity due to the pandemic. We see craniofacial abnormalities, abnormal neuromotor tone, the main conditions that are predisposing to the obstructive sleep apnea that Eva explained earlier. The gold standard at our centre, bearing in mind we are a specialist children's hospital and we do get the severe of the severe cases, and we do cardiorespiratory and polysomnography, which is the gold standard for the diagnosis of this disorder. And as Eva mentioned, just to reiterate the importance of picking all these different conditions up, because children with sleep apnea experience an increased prevalence of enuresis, bedwetting overnight, elevated blood pressure, that excessive daytime sleepiness, hyperactivity that often gets accused of ADHD, learning problems, inattention, and neurocognitive dysfunction. So the successful treatment of paediatric OSA requires a multifaceted approach, which will address all these different conditions related to the dysfunctional airway during sleep. And as you can see from our experience, we're good at showing them the pictures, and this is one of our staff's children having a sleep study. They always rope us into doing the research and get us, and I think I've had all my family wired up, myself, and I think the last time I got wired up, I was out in 7 minutes and I woke up sweating because I went in the biggest pink fluffy pajamas ever. Thankfully, I didn't have any sleep apnea. I think I had one short central, and it was quite unremarkable. So I like to give first-hand experience of what happens so you can tell the children, reassure, and that's why we are nurses, and advocate for those patients so we can explain the whole process. I used to do it back on M2 and have an NG tube down my nose, and you know, the lengths we go to, mud runs and all sorts, anything to help these kids and provide that ultimate reassurance. And I had to put this clip in of the clips of snoring. The hospital has now gone digital, and these are the screens that are walking around the hospital. So I'm just doing a bit of promoting for the Children's Hospital with the digital platforms that we now undertake the hospital. So we're really good at passing on these videos to the consultants to make them aware we need to sort the medical out for obstructive sleep apnea. So the treatments, I'll just skim quickly over these because Heather has amazingly explained these. It's the onward referral. And when I saw this picture, whatever showed up earlier, and when I was doing this slide, I was, gosh, I miss being in clinic, and we're just returning back to face and looking at these large tonsils, you know, and you're thinking, oh my goodness, what size are they? And they're touching, so quite remarkable. So it's good to have that face-to-face clinical judgment. The weight loss program, I'm keen as a fitness fanatic and runner myself to get them referred and help with the NHS Active Shine referrals, you know, to get them losing weight. Some children have to watch and wait. They may grow out of symptoms as the airway grows. As we know, as Evan mentioned, it's age 3 to 4, and I remember too well with their growing airways. It's important sometimes to watch and wait, but we keep them in for regular sleep studies and regular monitoring, and that's what we can pick up in our clinic. You know, if they've been delayed and we get them back in and referred in, we're really good at checking this out. The non-invasive mechanical ventilation, either the CPAP, sometimes BiPAP was required. I remember too well calling ICU and asking them to come and help me and setting people up because they were so bad, you know, overnight. And quick intervention really is the key to helping these kids. And there's other interventions that Eva's mentioned, nasal steroids, tracheostomy and jaw advancement, but these are the really severe ones, and we're quick to get them on ICU, so it's good. So this is a case example, and you're not going to believe this. This was just a couple of weeks ago. This child came into clinic, just a nurse-led clinic, reading the history. And I was like, oh my gosh, she's on CPAP already. It had consultant review first. They worked out, they did a sleep study straight away. They got him in with basically, was it a week or 2 weeks when I looked at the history? And CPAP was commenced immediately. His obstructive sleep apnea was so horrific. This 7-year-old boy taking the history had a global developmental delay. He presented with severe behavioural difficulties and commenced on the CPAP at night. Severe obesity, he was on the 99.6th centile. He also struggled with cardiomegaly, eczema, astigmatism and a seasonal wheeze. I was like, boy, 7-year-old, he's got a lot going on, bless him. Taking the sleep history, it came to light that before the CPAP, he was awake all night. There's no wonder, isn't there, with all these issues going on. He basically got no sleep, so the CPAP was a life changer for them. And to my surprise, he was due for adenotonsillectomy the next day after my consultation. I thought, gosh, this is a quick process. So I completed my assessment. I then fired my assessment to all the consultants involved. There was a respiratory consultant, one of our sleep consultants, and I said, I've just done this assessment. It's due for surgery tomorrow. When would you like the repeat study to see how he is off the CPAP, you know, to get him quickly weaned off? Not that I want to get him quickly weaned off, because that's where my work's going to start, because the CPAP sorted his sleep, but prior to the CPAP, he wasn't going to sleep. So there's some groundwork to do. So I'm still in this process, so I may be able to let you know how I get on with this little man later down the line. So I've become the nurse advocate for helping get this boy on a journey to better sleep. We've ruled out the medical, and I've come in further down the line. So it's a constant process, check-in, rechecking, and he'll be on our radar now to make sure that if he still needs the CPAP following the surgery, he could well do. So it's important to keep out. It's also important to choose the right time when commencing, you know, any work we do. So we always choose the right moment when we're going to commence, you know, our sleep therapy. And the crucial part is learning them to sleep post-obstructive sleep apnea. Because like I mentioned before, we are creatures of habit. And once you get into that set routine of waking constantly through the sleep cycles, as you hit that deeper REM sleep, when most obstructive sleep apnea occurs, that is when we need to do the work to get them sleeping back on track, because they're used to waking, it becomes part of their routine. So the life-changing impact, well, it's improved growth, it's that utter emotional regulation, the improvement of the BMI, improvement of cardiovascular system, the educational attainment in school, physical activities improve, their development improves, and I've seen firsthand, you know, no matter what condition they have, if they're atypical or they've got comorbidities, it's a real life-changing impact when you can improve, you know, and resolve sleep apnea. Even going on a CPAP, you know, we regulate, educate, and if I find someone's got sleep apnea, a lady at the local cafe pre-COVID mentioned she wasn't using a machine. And I was like, oh my gosh, get on your machine. It's life-changing, prolongs your life. And I can see it firsthand, and I've seen it firsthand in these children. So any adults, you know, I can really appreciate it can have a life-changing impact. So enough of me, I'll pass you over to the lovely Carolanne that can give you the first-hand experience. I'm looking forward to listening. And I'll come back for questions later. Thank you.
Thank you, Janine. I think Kath's put a comment in the chat, but your passion and commitment is absolutely inspiring. It really is.
Really is.
So
I have tears in my eyes.
I know.
A great team you two are. You really are. Both with such passion. We might just pause actually for a little question here from me while I'm unmuted. Heather, I spoke to you the other night and we was talking about, you know, tonsillectomy and how, you know, it could be as much as 90% of children are cured, which is fabulous if it's obviously to do with the tonsils. But one of the things in our group, which has got thousands and thousands of adults, and people will say, as an adult, which is rare, as you know, because we try not to take tonsils out when you're, you know, getting older. And they'll say they're going to try a tonsillectomy to see if they can get cured of their sleep apnea. And immediately Carolanne will agree in the group, well, hundreds and hundreds will say, well, I've got no tonsils and I've got sleep apnea. So I'm thinking, is it, you know, probably likely that you can, you know, remove the tonsils and a child can be fine, but perhaps it comes back later as an adult?
Yeah, thanks, Kathy. That's a really interesting question, isn't it? Yeah, I suppose as paediatricians, that's a difficult question to answer from clinical experience, because we then don't see the children again, and then we don't know which ones come back with problems later. But it is certainly something that's been discussed in the research and at conferences and things as well. One of the questions is, well, why do some children get big tonsils and adenoids and others don't, when most children get exposed to the same viruses at nursery and primary school? Why do some children who have tonsils touching in the middle, like the pictures that Janine and I have shown, don't have sleep apnea, and others that smaller tonsils do have sleep apnea? So it's not, the severity of sleep apnea isn't necessarily correlated with the size of the tonsils and adenoids. So there are obviously lots of other factors going on, as well as just the big adenoids and tonsils. And it is possible for, you know, children with obstructive sleep apnea, if their oxygen levels are okay and their sleep isn't being disturbed too much, to just leave them and not remove the tonsils and adenoids, even if they are really big. And eventually they will improve, you know, on their own without having to have the surgery, for those that, yeah, as I say, the ones that are not severe. So yeah, there are lots of factors, and I think it's related to the airway size and shape, the tissues, and around the area. As I said, there are genetic factors. It's to do with airway tone, so that you know, how strong the muscles are in the airway. It may be that the children that end up having their tonsils and adenoids removed, yes, they've got big tonsils and adenoids, but they might have some underlying problem as well. And then, as you say, then it can come back again later on in life.
Yeah.
So
I was wondering if as we grow older, we're probably losing muscle tone.
yeah.
So we might, well, one of the things, you'll know the clinical term, I don't know it, but when I can trace my sleep apnea back to childhood, even sleep paralysis when I was very young. And I went through a stage where I actually did fall asleep without my mum sat on the bed. And then when I was about 15, I think it was, I went to the doctors. I was always having tonsillitis, pharyngitis, and laryngitis. And it's the only thing I ever held when I was a child. And I went to the doctor and he said, well, we need to get these tonsils out. So he, you know, because it had happened too often. So he looked down my throat. He said, you've had them out. I said, no, I haven't. He said, you have, my dear. And I'm thinking, I can't remember the ice cream my mum had when she told me she'd had her tonsils out. Anyway, he had another look because he realised that, no, I hadn't had them out. So I don't know the clinical word, or the medical word, I should say, for it, but apparently they dissolved.
Yeah.
Now, when I was at that age, you know, 14, 15, 16, I was actually a lot better. So, you know, did nature lend a helping hand, perhaps help me function better? But then as I got older, obviously it came back and it ended up with severe sleep apnea. But it's, you know, quite a mystery. And so, like I say, I would say 90% of the people in our group don't have tonsils.
Yeah.
Who have got, you know, sleep apnea.
As I said to Tim earlier, the peak age for big tonsils and adenoids is 3 to 4 years.
Is it?
That's because they are part of your immune system, and they do enlarge when you know, the immune system's really active in fighting recurrent viral infections. And then as you grow older, then yeah, they regress, they shrink, because they're not needed for that function anymore. So yeah, they do naturally shrink.
Oh, very interesting.
Or whatever you want to, however you want to describe it.
Yeah.
And then, as you say, and then other things take over as you get older, like the muscle tone, and the size of your airways.
Yeah, very interesting, isn't it? Really, yeah. Right, thank you. So we're now going to hear about Carolanne. Now, Carolanne's family, I think, have you actually got shares in the CPAP companies, Carolanne? Because in your extended family, I really think you do keep them going, don't you, with the amount of machines?
I think we've got 7 now.
7 is there, yeah, because I know there's a question in there which I was about to reply to from Kelly, I think it was, saying about how her mum has sleep apnea, she has sleep apnea, she's not got children yet, but she wonders, could this happen to them? One thing I will say, Kelly, is that it definitely runs in my family, but so far the grandchildren sleep nice and quiet and even, and we're hoping that continues. So, you know, it doesn't have to, you know, follow, but it, you know, it obviously does a lot. You know, it is a hereditary factor.
I think an important point that Heather made in her written reply, which is just worth pointing out, is that even if it doesn't, it's being aware of the signs and symptoms, and if you do notice them, you obviously take them straight to the GP at the earliest opportunity.
Absolutely, and don't get fobbed off. And that's the other thing, you know. It's you know, as Heather said, it's not normal that a child should be stopping breathing. I do remember when Katie was very young, and I didn't know anything about sleep apnea then. And she, as far as we know, she doesn't have it now as an adult, but perhaps there was a little bit of it as she was young. And he just said, kick the cot, you know. And, you know, hopefully she's okay. And like you said, watch and wait, maybe she's, you know, hopefully she's fine. But I do remember my GP saying that, just kick the cot if she stops breathing. So Carolanne, you would have been kicking all night, wouldn't you? Yeah. So so Carolanne, as well as it running in you know, the line of her adults in the family, Carolanne herself has upper airways resistance syndrome, which is another webinar for another day. And CPAP has really improved that for you, hasn't it, Carolanne? And your husband, obviously, he's got severe sleep apnea. And Carolanne has 4 children, and 3 of them have a diagnosis of sleep apnea. Maybe even the 4th for all we know, but 3 confirmed diagnoses. So really it's over to you, Carolanne, because we know at the charity how much parents do struggle to get ahead and to get referrals to the right places. So, you know, are you going to tell us how difficult that was?
Yeah, even though we've got all these CPAP machines in the house, it wasn't until Travis was born, which was 13 years ago, that we heard the word apnea for the first time, and we haven't got rid of it since. We unfolded a family history at that point, and we had 3 CPAP machines, and we've actually had 4 at one point under one roof. But my oldest son, he's now married with 2 children and has his own home. And like you, our grandchildren show no signs of sleep apnea. So even if it does run in a family, it doesn't mean that everybody is going to be affected by it. Travis was born with laryngomalacia, which is generally a floppy larynx, which is in your upper airway. Martin, our oldest, was born with it also, so we knew what it sounded like and we knew what it was. Travis also has vocal cord palsy, so his vocal cords sometimes don't do what they're supposed to do. So really his upper airway is quite floppy in general. In moderate to severe laryngomalacia, sleep apnea can be common. But they say about 90% of children will outgrow laryngomalacia by the age of 2, and it's just really a noise that they make when they breathe in. Doesn't have a lot of effect in the milder laryngomalacia. Unfortunately for Travis, he had severe, and he also has Ehlers-Danlos syndrome. He's got reflux, which he's had since birth. He had an operation for that, but still takes medication, and he's also tube fed. So he's quite complex. There's sort of lots of things in the background. In 2010, when Travis was 3, after lots of sleep studies, it sort of showed mild or normal events. He wasn't growing properly and became failure to thrive, that's what they called it. He just wasn't growing correctly. So they referred him to Glasgow for an in-depth sleep study, the polysomnogram, which Heather had talked about, and Janine. And that showed a totally different picture. he was using muscles that he shouldn't have been using to breathe. He was retaining carbon dioxide, and he was only taking 11 breaths a minute. And I think the average, correct me if I'm wrong, the medical people, I think is about 30. And so he was breathing quite slowly. So he had emergency airway surgery the following morning. He had his tonsils removed, his adenoids removed. He had a supraglottoplasty where they laser the floppy tissue around his larynx. We were given 2 months post-surgery to see improvement in his growth and his general breathing when he was asleep. And if not, we would be trialing CPAP. But in that 2 months, he began to grow slowly. He had no more serious struggles to breathe. I can only describe him as, if you imagine blowing air into a balloon and letting the air out, it was very, the whole bed moved and his whole body moved. We could hear him, in different rooms. You could hear him outside. He was loud. But yeah, for Travis, pre-surgery, he would go to bed at 7 o'clock. He would sleep all night, waking up at 11, have breakfast, and then have a 4-hour nap. And he was under 3 at that point, so we didn't get the terrible 2s because he slept through it all. But obviously now we know it's because he wasn't getting rested sleep, during the night. He's still being regularly monitored. His laryngomalacia is just about resolved. We only hear the noise sort of when he has a cold now. And we've got such a huge family history that we are on a watch and wait. He currently uses a nasal steroid spray, which has good effect. So currently surgery fixed him. Then Jaden arrived the year before Travis had his airway surgery. And he also had laryngomalacia, reflux, and Ehlers-Danlos. So we had a 2-year-old and a newborn that both had sleep disordered breathing. How on earth me and my husband are actually still married after that, I question it every day, because we must have been so sleep deprived. Having a newborn is hard, but having a 2-year-old and a newborn and them not watching them sleep, really, I think we just watched them sleep through the night.
And at that point, you two weren't diagnosed anyway, were you?
No.
So you would be struggling much worse.
Definitely.
With your own.
Yeah, I think Donnie got diagnosed in between the surgery, and I think it was after Travis's surgery that he got diagnosed, and he was severe. He was, I think he was 30, I think his AHI was, and the morning after his sleep study, he came home with a CPAP machine. So yeah, thankfully. So in a way, a positive out of the negative situation is that Donnie was diagnosed because he'd had it for years and was undiagnosed. So yes, that was a positive in it.
Yeah, that's even worse.
Yeah. Jaden's diagnosis was a lot easier than Travis's. Obviously, Travis took quite a while to get treatment because he was 3 at the point. From birth to 3, we'd sort of been questioning, and so Jaden was much faster based on his brother's experience. So we were given an apnea alarm monitor, which gave us reassurance as it would alarm and let us know when there was an event, so we could try and sleep. But it also, on the other side, disturbed our sleep because it would alarm so many times throughout the night. And there's nothing worse than waking up to an alarm and going, gosh. And then sometimes we took him to the local hospital, and by the time we got there, he was awake, he was alert, his O2 was good, and it was like there was nothing to see because he was awake. So we began to feel that they must have been disbelieving us because we were saying one thing and they were seeing something totally different. But actually, it was because he was awake. It's because he was no longer sleeping. So Jaden had regular sleep studies from about 8 weeks old, I would say. His consultant was really good and on the ball. And at one point, his breathing was concerning to her, and she referred him to Glasgow because they had dealt with Travis, obviously. And Jaden had a sleep study and was put on the waiting list for surgery. So he had tonsils, adenoids, supraglotoplasty, which is the lasering of his larynx. And it had good effect, but his stridor, which is the noise they make with their floppy airway, it was still quite intense, and he was using muscles even during the day that he wasn't meant to be using. So they gave him another supraglotoplasty just to take whatever was left in there. So, you know, his upper airway then had as much room as possible for breathing. That didn't really make a lot of difference. So they started him on a CPAP trial. We had sent videos because obviously Glasgow to here is about a 4-hour drive. So we would send videos showing the extent of his breathing when he was asleep. And his consultant had said, you know, we'll book you and come down and we'll trial CPAP. Jaden took to CPAP like a duck takes to water. Initially, it was kind of like having a newborn because the mask, as Heather says, you know, they slip, they cause leak alarms, and he would pull it off his face. But generally, within 2 weeks, he was sleeping 7 hours, waking up, having a drink, going back to sleep for another 3 hours. And we then got the courage to move him into his own room. And this is him at nearly 4, co-sleeping for 4 years. So we then sort of moved him into his own bedroom with baby monitors. So when his mask would leak, we would hear the alarm through the baby monitors. And I think that is the first time we got proper sleep as parents, because you had the reassurance that your child had support to breathe. They weren't going to stop breathing. You know, the fear of that disappeared. So as much as it was quite difficult to start with to get him adjusted, because obviously he wasn't used to sleeping with something on his face, and the hose would be cold, and you know, generally it was about 2 weeks, and it was as if he had slept with it since the day he was born. So he no longer got chest infections. He used to get repeat chest infections, pneumonias. He used to be able to sleep standing up. He was also at one point so frustrated due to the poor quality of sleep that they thought he had ADHD or hyperactivity disorder. But within a month of using the CPAP, it was very evident it wasn't that. It was poor quality sleep that was affecting his mood and his behaviour. Literally, it left at the same time as all the bits they took out of his upper airway. It was night and day, really, the change in his behaviour. So when Jaden came home on his CPAP, we had 3 apnea diagnoses and 2 CPAP machines in the house. Our 14-year-old at the time that Travis was born, he slept a lot, made gasping noises. I could hear him if I was in the kitchen and he was upstairs breathing, you know, squeaking, gasping. So we went to the doctors and they had dismissed it as being normal. Teens sleep a lot. And he was our first teenager, so we had nothing to compare it to. So we presumed snoring and sleeping lots was a teenage thing. So 2 years later, when he was 16, and by this time I was obviously an expert parent, I went back to the GP, because obviously I had one husband and 2 kids that had apnea, and 2 of them were on CPAP. So I knew with Martin that there was something just not right. My gut told me that I needed to go back, and he needed reassessed. He also was depressed at this point. He was on antidepressants, and he had quite bad anxiety, which wasn't him. He, you know, it was such a change in his character. He also had laryngomalacia as a baby, and the stridor noise, the noise that they make with their airway, came back at 16. So I went back to the GP with him. He was referred straight away for a sleep study, and the results of that were sort of borderline for sleep apnea. It was very mild, but his Epworth score, which is to determine how sleepy you are, was exceptionally high. So at this point, I discovered Cath and Hope2Sleep, because I was on a mission at this point. Then I knew that the results couldn't be right based on what we were seeing. So I was looking for a private sleep study at that point, and I discovered Cath, who spent hours on the phone. And we did one of Hope2Sleep's private sleep studies for 3 nights. The results of that showed that there was variation night to night. 1 night was mild, and 2 of them were sort of in the moderate range for apnea. So we went back to our local clinic with those results from the Hope2Sleep study. And he was very lucky in the fact that they gave him an APAP trial based on those results. He had variation for whatever reason. It could have been sleep position. I don't quite know. But a few years later, he was diagnosed with Chiari malformation, and he had emergency brain surgery. And we know in studies that Chiari can have, I think it's 50 to 70% of people with Chiari also have sleep apnea. For Martin, again, it was life-changing. He came off antidepressants within 6 months. His mood, his sleep, everything about him changed. And I thought that I was really sleep deprived, obviously, based on the fact that that's 3 children and a husband. And Cath kept nagging me constantly to get a sleep study. So 6 years ago, just to shut her up, I did the sleep study, and it showed that I had upper airway resistance syndrome. And I also was given a CPAP machine. Most people have bedside tables with lamps. We've got bedside tables with CPAP machines. But as Janine said, it is life-changing. People usually say that about a lottery win. The only other description that I could come close is night and day, because it's such a contrast. My advice to others would be, as you say, if you hear snoring, if you're concerned about the way your child breathes, go to a GP and get it checked out. And video for us was key. I think when you try to describe something, it doesn't or can not come across the same way as them seeing it with their own eyes. So for us, video was key in more than one diagnosis.
That's what Heather said, wasn't it?
Yeah.
And Heather said how much they welcome it as well, which is good, because some people say, oh, will they take notice of them? Heather says herself how helpful it is.
Yeah.
So I did have 2 more questions, and one of them was, what advice would you give? But you've just given it.
I jumped the gun, sorry.
It's all right.
This is the first time I've done this, I apologise.
You see, and I had another question. What was the difference in the children? And you've actually already told us that as well.
Sorry, Cath. I'm not trying to cut you out to not talk.
That's
Tim didn't hear me.
I have a feeling Tim's had a quiet word with you.
I'll give you that tenner later on, Carolanne.
But it really is incredible, isn't it? And when you listen, I mean, I appreciate Carolanne as the extreme, as in the amount of other family members and 3 out of 4 of her children. But even so, every adult who has sleep apnea really needs to you know, observe the children in case it is running in the family. And sometimes we get it that way around, don't we, in the group, Carolanne, where we, you know, well, you're a prime example, she's there for the children, and then the next thing is Carolanne's on CPAP and her husband's on CPAP. And then we get the other way around, where we've got adults come in, and then we actually prefer to have the children and adults, not the children, but the parents of the children and adults in our group, because of the importance of seeing, you know, it affects, you know, people of all ages, all sizes, and it sometimes as well, you know, some of the adults, you know, and I've been guilty of it as well, you know, we moan like mad, and then we see these pictures of these children. I wish I had that picture of was it Jay? Yeah, his dad, and also you know Emil, don't you, Heather? Yeah, little Emil. All the pictures I have of Emil, you know, smiling away in his CPAP. The children are no different because they're just so happy, you know, because they're treated. It's the children who aren't treated, you know. So as I say, it works both way around. An adult will have sleep apnea, then find the child does, or a child, you know, the child has, and then they find they themselves have it. Because obviously it does run in families, and you know, yours is an amazing story there, Carolanne, and she has a lot of challenges with the children, and she never fails to support all the others in our group. And thanks for all you do for us at the charity as well.
Well, it's paying back for the time that you spent at the point that I was looking for help. You were there, so it's you know, it's paying it forward. And some of the time, because we're so rare, we're under genetics, and you know, we've got so many complex and different issues going on. Sometimes I don't want to scare parents. Sometimes I think, oh, you know, I might scare them off, you know, based on our, you know, we're the rare side of things.
You are the extreme, yeah.
But I think it's important to highlight that.
Yeah, but it was still, you know, important because of the three differences in the children as well. You know, different treatments. One manages without CPAP. And hopefully will continue. Martin, now I remember Martin, she's talking about, now I remember just before we was a registered charity, the first donation we ever got, because when people thought we were a charity, a lot of people used to try and donate, and I used to say, well, I'd rather you didn't, because we are officially registered at the moment. But I remember Marty, he did Movember. He was 17 years old, and he was so grateful for his new life, wasn't he? When he was on treatment, he did Movember. And so Carolanne said, you are taking this money. So we held on to it until we was a registered charity, and Carolanne's eldest son was the first donation we ever got.
You still can't grow a moustache or a beard, Kath.
Yeah, he's in fact, I seem to remember that he wants, am I right in remembering that he actually wanted a better machine?
Yeah.
And he sold, what did he sell?
His PlayStation.
Yeah. So he could get a better machine. How about that? That just tells you what it meant to him, doesn't it?
Yeah, at 17, getting rid of your gaming station to buy a sleep device. Yes, that just shows how good CPAP is.
Yeah, absolutely. Thank you.
I've known you for a couple of years, Carolanne, and I think you always touch on sort of your family history on our charity calls, but I've never heard the whole thing, and it's just incredible. So thank you so much for sharing this evening. You did fantastic, because I know you were nervous.
Yes. You didn't.
No, absolutely brilliant. Thank you.
Thank you.
We've had a couple of comments and questions too, so if we cover those before we turn off for the night. First of all, there's just a very complimentary comment about Janine's presentation. and comments. So just a big thank you there. And then we've also had a question. What is your opinion on the homeoblock myo brace to help with opening up airways by jaw expansion? I'm sure who's best to answer that one.
Heather.
Yeah,
Oh, Janine.
I'm not an expert on those types of therapies because we don't really do very much of that sort of thing in children. The surgeons would consider things like jaw expansion if there was an actual anatomical problem in the airway. So there's palatal expansion, where you can actually expand the palate sideways. Or you can extend the jaw in cases. So, for example, the picture of the baby that I showed you with the Pierre-Robin syndrome, you can do maxillary expansion, which is expansion of the jawbone here. So, yeah, those sorts of treatments do exist for children, young children, really, with very specific conditions. But otherwise, there isn't really experience of that kind of treatment in children. I think there's a lot more sort of evidence in adults than in children.
Would that be because of the children growing? Would it, would they wait until they'd stop growing before they tried that type of surgery?
Yeah, I think because you're going to see how much a child's going to grow anyway, aren't you? Yeah.
Yeah, yeah. Because I always remember years ago, my godmother, who nothing to do with sleep apnea at all, except she was a dental nurse. But I still remember her saying that we're going to have a problem with shrinking jaws. I'm going back, by the way, probably about 50 years. And she said, we're going to have a future problem with shrinking jaws because the dentist said, I've told man, she said, they're taking too many teeth out. And she said the jaws are going to shrink. And years later, I can see, how it has become a problem. And same with the overcrowding with the teeth. Sometimes you'll know yourself, I'm sure, Heather, because we even see it in adults, that a patient will come to you and just to look at the teeth, there's a problem, don't you? Yeah, it's quite interesting, really, how it's all connected.
We just had one from Sally, who's actually Kelly's mum, who asked the question earlier, asking if OSA can actually skip children but appear in grandchildren. Going back to the hereditary question earlier.
Yeah, it can do. So as I said, there are some genes that have been studied and found that kind of show a link through family generations in terms of sort of specific anatomical problems, a bit like Carolanne's family. But I suppose it's sort of a bit like hair color or eye color, that sort of thing. It doesn't necessarily affect every generation, but those genes can get passed down and might express themselves in different ways in different generations. So it's not a sort of a direct genetic link. So yeah, it could skip a generation or be less severe in one generation and then more severe in another generation. I think that's very feasible. Yeah.
Yeah. I suppose that's like anything into any hereditary illness as well. Other illnesses that, or medical conditions that run through families, it can often skip generations.
Yeah, it depends on the genetic problem sometimes, but these are genes that are kind of not specific for passing it down in a particular way. So yeah, a bit more complex.
Yeah.
Great, thank you. There's some comments from Carolanne, but I wonder whether that might be better to follow up privately.
What's that? Are you still there, Tim?
I am, yes.
Oh, it's all right. I thought we'd lost you.
No, not at all. Although in true live event, it sounds like I actually have a family emergency. So would you be okay just to wrap up when you feel ready to?
Yeah. Are you okay? Yeah.
Yep,
Okay.
yeah, all good. But
Yeah,
thank you, everyone.
Yeah. All right. See you soon, Tim. Yeah. Emergency. He's probably had snoring from his child's bedroom and now he's very worried. Yeah. Have we got any here? Flair. My daughter has Down syndrome and is struggling wearing a BiPAP mask all night. I just wanted to thank Janine for her presentation and comments on established post-sleep behaviour, especially consistent waking. This really resonates with my daughter's sleep pattern and what we are trying to work through. Thank you. Do you want to comment on that, Janine?
Yes, it's a frequent occurrence when a child's got used to waking at regular times, whether it's you know, a taught behaviour or because of a medical condition. And obstructive sleep apnea is definitely a definitive, you know, problem, that because they kind of wake up when they're having that apnea, the body self-regulates, and it's just an automatic thing that the body does to help them breathe again, doesn't it? It gives them that obstructive, wakes them up, and then they go back into their sleep cycle. So once they've got over, if the adenotonsillectomy improves the sleep apnea, then you're left, because like I mentioned before, it's our bodies are creatures of habit, and like anything, even when you're dieting, you have to work so hard to get back on track. And it's just like sleep. It is, the circadian rhythm is so sacred, and when it's disrupted, that's what we spend half our time battling to get these families, children, just sleeping again, because the benefits of that pure, it's a free medication, isn't it? Sleep. It's just utterly amazing.
Yeah, yeah. I always liken the fact to, you know, although it can be a shock when even adults get diagnosed with sleep apnea, one of the things I'm the most grateful for is that such a serious condition, in most cases, can be treated without any medication, just a CPAP, just a mask when you know, when it's dark. You know, because so many other conditions you have to take a, you know, regular medication, and that can cause problems, so then you have to take something else for the side effects of that medication. But you know, that's what's so good, you know, for such a serious medical condition, that we actually don't need to take you know, drugs. And going back to what you was just saying as well, creature of habit, you know, with insomnia, you know, and again, I'm relating to the adults here, in that the fact that I would say about 90% of people with insomnia, once treated for the sleep apnea, the insomnia just goes away. But then there is, as you just said, creatures of habit. Sometimes you know, in say 10% of these people, insomnia is still going on because it's become a habit to keep waking. It's not. Is that who said that?
Me and you.
Sure. No, I don't have insomnia. I just go to bed too late. Yeah, but it's a habit. But actually, going to what you was saying, Carolanne, one of the shocks I got when I was told I was stopping breathing 32 times an hour on diagnosis. I said this the other night, I think probably to Heather and Janine, and I said, I was in denial because I thought he's got the wrong patient. And I said, if I'm as bad as you're saying, you'll tell me why I go to bed too late then. So he said, it's simple, because your body subconsciously knows sleep is a dangerous place. And that really did shut me up, actually. But I'm a creature of habit, and after all my, you know, that lifetime of going to bed too late, I'm afraid I do find it hard, you know, to go to bed early. And you're probably the same, aren't you, Carolanne, because of being up with the children so late?
If I go to bed early, then I tend to waken up 2 hours later. So my body thinks it's just had a nap, and then I end up with sleep. So I've got to keep a regular time, you know.
Perhaps we should go for a session with Janine.
That's what I was thinking when she was saying that. It sounds very good.
Yeah. Is there any more questions before we finish? Carolanne is saying, Carolanne Lambert, she is saying about the history. Let's have a look. She's got twin girls who are almost 7. They have both shown symptoms. They've been referred to ENT, did a sleep study, and were told they were fine. The one I was more worried about just had pauses for breath, and I've since been back to ENT, and eventually she was referred for tonsils and adenoids to be removed, which was done in December. She still snores really loudly, still sleeps with her mouth open, I think Carolanne meant to say. Oh yeah, I've got it on the next one. Yeah, mouth open, gas, wake up frequently with night terrors, sleep talk, sleepwalks. What does that tell you? Those are all the symptoms of sleep apnea, aren't they? And, you know, I'm sure Heather and Janine would encourage you, Carolanne, to go back to the doctors about this, because it sounds like it may not have been resolved. You know, perhaps where would you say to be referred, Heather, in these cases?
If possible, go back. If she's still under a consultant, then I would see if you can get an appointment back with the consultant. She's been discharged, then I would go back to your GP. But as we've said, if you can possibly take a video with you, just so that you can show them what you mean, it's much more powerful.
Yeah.
So
yeah,
good
that
luck.
video, Carolanne. Yeah, that video. You know, get the videos. And if you're in our group, which I think I've seen your name from our group, you know, feel free to share with us as well. And Carolanne and Janine are both in our group, and they'll have a look as well. And I think there's just one more here. Can a 7-year-old, my grandson, with visible epiglottis possibly have OSA? He has ASD, epilepsy, wakes frequently and sweats. His mother is recently diagnosed with mild OSA and is on CPAP. Do you want to answer that?
I think it's a difficult one, because there are lots of causes for waking up frequently and sweating at night. So it's less likely if he's not snoring or gasping or having any of the other respiratory symptoms. Oh, question's just disappeared. If you're concerned, I mean, so I would watch the breathing and see whether or not you think there are any of the symptoms of sleep apnea. And if you're concerned, then go and see if you can discuss it with somebody.
Yeah, and again, Carolanne, if you want to share any of that footage in the group with Carolanne and Janine, you know, feel free to do it. If you just sort of want a bit of confidence whether you should be going, you know, because sometimes it is a battle, isn't it, for the parents, and that's half of it is, oh, am I making a fuss, and it might not be anything. So sometimes just having somebody else look, you know, can really help, can't they? I think we've finished all the questions, have we?
Yeah, that's all of them.
Have we gone through them all? Yeah. Oh, Tim's back now. You can have your
Yes.
job. You can have your job back, Tim.
So yeah, so we've gone through all the questions.
Good.
So I'd just like to thank everyone. So Heather, Janine, Carolanne, and of course Kath, and for everyone joining this evening and for your questions. So the recording should be on YouTube sometime next week. So if you want to catch up on any bits, you're very welcome to. And we look forward to joining our next webinar.
Yeah, thank you, and thank you, Tim, as well. Thank you, Tim. Thanks. Bye, everyone. Take care.